This is the Psychcast by MD-Edge, where we bring you interviews with leaders in the fields of psychology and psychiatry, masterclass lectures, and relevant reflection and inspiration, with new episodes dropping on Wednesdays. I am the voice of MD-Edge Podcasts, Nick Andrews, and a producer on this show, and this is episode 117 of the Psychcast by MD-Edge. And I'm joined this week, as I always am, by Dr. Lorenzo Norris. And Dr. Norris, we've got part three, or our third installment of my conversations from TEDMED 2020 in Boston. And this is an interesting one. This is the kind of conversation that will bleed out into popular culture because it's got some sexy topics, and those topics are drugs, but the practical use of drugs, specifically psychedelics, and we'll get into all that. Welcome to episode 117. How are you doing as we're about halfway to summer now?
Yeah, we're about halfway to summer, Nick, and I am actually doing well, all things considered. I mean, all of us are dealing, obviously, with the social distancing, but I got to tell you, man, I really like the fact that summer is coming, get a chance to get out on the bike and do some things, maybe, get a staycation or something like that, work on your garden and get all that done. So, yeah, I'm doing pretty good.
That's good. That's good to hear. I know that you and I are sports fans. I have not caught up on the Jordan documentary, but it's coming to a close. I hear that the latest installment as we sit here in May was pretty good. I trust that you are at least abreast of the fact that there is a documentary about Michael Jordan.
I'm holding the fort for both of us up here on Nick. You got to catch up with me, though. But yes, I have watched the latest installments of it. And I got to tell you, they're picking up steam, in my opinion.
Okay.
And the other thing is that it actually put a bit of a different look or take on Jordan, particularly as it relates to leadership. I would encourage people to look at the end of, I want to say, episode 7, when Jordan is talking about the sacrifices of leadership, and watch his emotional response at the end. And that showed me another side of Jordan that's different from this brutal competitor that take all, win at all costs. I mean, don't get me wrong, that's all still there too, but it just offered a different side. So for that, I thought that I reflected on that a bit.
Absolutely. Heavy is the head that wears the crown, as Shakespeare so eloquently put it. But let's talk about heavy heads in a different way. The guest this week is Dr. Frederick Barrett. Dr. Barrett is from where I am right now, Philadelphia, Pennsylvania, which is something he and I discuss. He's at Johns Hopkins, where he is studying how psychedelic drugs are impacting psychiatric patients with different things going on. We've seen about this perhaps in the New York Times or the Washington Post, but it's gaining steam, and Johns Hopkins leading the way in the research here. But in reality, when do you think this could possibly, like a ballpark, when it could be clinically relevant? How close of attention should clinicians pay to this? And how exciting would it be to be a researcher at Johns Hopkins?
One, it would be extremely exciting to be a researcher at Johns Hopkins and various places that are doing it. But Johns Hopkins, premier institution, really great folks. I remember interviewing there as a resident, and I was for residency, and I was really blown away the fact that the residents rotate in the ICU, which blew me away. But in regards to what you're saying about is this clinically relevant right now, I would absolutely say it's clinically relevant right now, because if for no other reason, our patients use LSD as an example. People use psychedelics, and one thing that I like to think about is that our patients have used, whether it's ketamine, cannabis, what have you, our patients are actually using these medications for various reasons. And so whether or not you're prescribing it or not, you actually do want to understand the effects of LSD. And in particular, with what Dr. Barrett is looking at, which is really super duper cutting edge stuff. I mean, the area of the brain that he's looking at, if you will, the clustrum, is the most densely populated area of the brain, which is kind of crazy when you think about it. It's that's like looking at the, New York City in the state of New York. I mean, it's just nuts at what is going on. And for those of you, if you're not up on your neuroanatomy, that region of the brain is postulated to link the prefrontal cortex, all right, with subcortical structure. So basically, your cognition, proper cognition or whatnot, with, if you will, your emotional core of your brain. So that's definitely the super highway of it. And he's looking at that, and he's looking at the impact of LSD, along with one of my favorite topics, music, art. He's basically, when you're starting to look at, he's basically trying to look at states of consciousness, which is great because no one has figured it out. So, I'm really curious to see what he has to say.
Yeah, absolutely. And his TED Talk will drop live. TEDMED, of course, as we reported in episode 116, is defunct, or at least not defunct, but on hiatus as a result of COVID-19. We're all feeling the effects. But his TED Talk will drop as scheduled. And until then, you can listen to the interview, which is, of course, following our intro. Following the interview, Dr. RK is back this week, and she's going to dive into something that we've all had a period of time to digest for 10 to 12 weeks, if not longer, which is telemedicine. We know there's a lot of psychology and sort of lower level, light outpatient stuff going on with text messaging and new apps. But now that COVID-19 has forced us all indoors, telemedicine is really big, and psychiatry, of course, is a specialty that lends itself particularly well, especially if patients have the resources to look in a camera and see their physician.
Okay. Nick, you're bringing up some very good points. And one, with telehealth, the thing that I'm thinking about, and I'm working actually on an article for this, is how do we actually leverage telehealth services along with, for lack of a better word, where we're at in terms of just our informational capacity and digital networks and things of that nature. Because the way I think about it is that you can do a whole lot more with Zoom than talk and, if you will, listen. Because if for no other reason, if you think about it, when you're doing telehealth now, depending on where the patient is at, they're not coming to you. You're actually getting a privy into their setting, which is a completely and totally different dynamic. Whether you start combining that, which I think is ultimately going to be something we're going to go in the direction of with apps,
Sure.
where you start combining that with things that incorporate biofeedback. I'm waiting for somebody to do the kind of the holy grail, if you will, of app biofeedback and app watches and telehealth. And that I think it's out there. Someone's doing it. I just haven't had a chance to look at it. And then the other thing with telehealth that becomes rather relevant depending on where you practice. And I want to say this came out in a conversation that we had with Dr. Jack Roselle. That's going to be a psych guest that's going to be dropping a bit later. There's telehealth and then there's the telegap. You take for granted that, everyone assumes, depending on I won't say everyone, but a lot of the listeners in this audience, maybe you're listening to this on your Android or your iPhone or X, Y, or Z or this, that, or the other. You take for granted that you assume everybody has like a nice HD camera. A lot of people don't.
Right.
For a lot of folks, that phone connection can even become hard to come by. So as we continue to think about telehealth, I encourage people, and I want to give Dr. Roselle, UPMC, our person who really talks with us about gun violence a lot. I want to give him a lot of credit. He may not have been the first to say it, but I really liked when he said it in terms of there's a telehealth and then there's a telegap. So we need to think about this, and it's always look forward to hearing RK. She and I got to do a podcast.
Yeah, no, we're working on that.
Really, this is. I gotta do a podcast with RK. You got to get caught up in the Jordan document.
Yeah.
And but right now though, I am definitely, this is nice, Nick. This is nice. I'm really looking forward to this podcast from Dr. Barrett on LSD. So as well as hearing RK and her musings about where we're at in telehealth.
Absolutely. Dr. RK coming up after the interview, and after this, we will bring you my conversation from TEDMED 2020 in March with Dr. Fred Barrett about psychedelics and a bunch of other states of consciousness as therapy. This is the Psychcast from MD Edge. Welcome back to the Psychcast. I am the voice of MD Edge Podcasts, Nick Andrews. And before we get to my interview with Dr. Frederick Barrett, a quick reminder that you can reach out and contact the show if you have any ideas for episodes or guests or topics. That email address is podcast@mdedge.com. And of course, you can interact with us on Twitter @MDEdgePsych. You can find links to that in the show notes. The show notes this week were authored by Dr. Jacqueline Posada, who has hosted the Psychcast before. They are excellent, and they are available wherever notes are found in your app. They include an outline, key takeaways, and some links to references mentioned in the conversation. Okay, from TEDMED 2020 in Boston, my conversation with Dr. Frederick Barrett. We're here at TEDMED to talk about some new research happening at Johns Hopkins, which is where you work and where you are. This is an innovative situation. And for people that follow the Washington Post and New York Times, there is a psychedelics clinic at Johns Hopkins, or psychedelics research. And do you just give me just a quick bullet point on what you guys are doing there?
The Johns Hopkins University Center for Psychedelic and Consciousness Research was recently established in order to basically move the field forward as best we can in terms of trying to dissect and discern, particularly what medical indications may have the most promise for being treated with psychedelic drugs. We don't have a clinic yet because psychedelics aren't approved as a medication.
Sure.
But, I think the ultimate goal is to really truly determine whether psychedelics do have a medical indication for which they're effective.
So when you started this, what kind of research prompted it? Like, how did you have a hypothesis to get to this point? Because it's very stigmatized, and obviously you go back to the 60s. Of course, these professors at these East Coast schools are giving people LSD, and it cures everything. How did you get to the point where you can say, actually, there might be something to this?
Well, it's a rich and sordid history. When psychedelic drugs were first explored in the 50s, really in the beginning of the 50s, they were explored on two fronts. On one front, they were explored as a potential model for studying psychosis, with the idea being that if you had this compound that could temporarily induce some psychotic features, you could then study the process. Afterwards, the volunteer comes back and they're healthy, and you haven't hurt anybody. But in the meantime, understanding the mechanisms underlying all of those effects could really give us some insight. It turns out that psychedelics are actually very poor models of psychosis. They're far better models. But in the process of figuring that out, another line of research altogether was pursued in terms of trying to figure out whether these drugs could have any efficacy in treating substance use disorders. One of the first therapeutic studies that was conducted with LSD was conducted by Humphrey Osmond to treat, at the time we would call them alcoholics. I think we'd say they have an alcohol use disorder now, but these two research programs were running in parallel up through and into the Controlled Substances Act of 1971. So when the Controlled Substances Act was passed, nearly all of this research was put on hold. And in more recent years, in the late 80s and early 90s, Rick Strassman at the University of New Mexico at the time began to study psilocybin and dimethyltryptamine, but it wasn't until my mentor Roland Griffiths at Johns Hopkins University got involved beginning in 1999 that then the first psilocybin study in the United States was conducted and then published since the Controlled Substances Act. That initial study was really geared towards understanding the basic subjective effects and to some degree the safety profile of psilocybin, but that then opened up the doors to forgive the potential psychedelic reference to the Doors. They're not really psychedelic.
No, Jim Morrison's pretty good. Yeah.
Sorry.
No problem.
So that kind of opened the floodgates in a way. It showed people that the FDA itself would not necessarily just be blanket opposed to studying these drugs if you came up with a good rationale and a safe way of approaching it. Of course, this is possible to conduct this research, and from that point, people kind of picked up where they left off, studying primarily mood disorders and substance use disorders.
Do you get the impression that people were kind of sitting around thinking, man, if it wasn't for this act, we would be all over this, and now they're excited to kind of get back into it?
Well, certainly preclinical research continued during this, if you will, kind of prohibition. It wasn't really an exact prohibition, but preclinical research itself didn't necessarily stop, and preclinical research continued at such hallowed halls as Harvard and Yale and various other institutions. I think a lot of people were waiting in the wings for a time when we could return to really objectively studying these drugs.
Yeah, and I think that it seems like there's a lot of movement. I very vividly remember watching a documentary by the disruptors of journalism, Vice, about how the heroin use disorder patients were going to Mexico to get a psychedelic called ibogaine. I don't know much about that drug, but they swore by it and said, this is the only thing that's ever given me any chance of hope for this. I thought, well, maybe we should look into that. That seems like it could be something that is worth looking into. So now, do you feel that, and this has made national headlines, do you feel that you have momentum?
Well, so ibogaine itself is a tricky drug, and it's a really good example of how tenuous this all still may be.
Sure.
Because ibogaine itself does have real medical risks, cardiac risks, and the application of ibogaine, and also in many cases ayahuasca, in other countries where it's an illegal gray area, or maybe not sanctioned, but it's not punished. It's the wild, wild west. Sure. There seem to be some good actors who may be approaching this in a reasonable and ethical way, but there are also bad actors, and the underlying question here is, well, are people going to eventually get hurt? People are already getting hurt in some cases. At one point, do we treat this as a medicine, and at one point, do we really try to understand from the models in modern medicine what the risks and benefits are? I think we're at a point where we can begin to ask those questions, and I think we have a lot of momentum in approaching those questions from a really objective perspective for two reasons. One is there do seem to be an overwhelming number of anecdotes of people who have claimed to have benefit from these drugs, and there are so few successful treatments in psychiatry. Certainly over the last number of decades, nothing new has really popped up except for ketamine, possibly.
Yeah, sure.
And ketamine is doing some wonderful things, and MDMA for PTSD.
Just going to bring that up, yeah.
Is doing, there are some really good reasons to think that MDMA and ketamine are really going to help people. And the next natural question is, well, okay, that's great. If MDMA can help people with PTSD, if ketamine can help people with treatment-resistant depression, is there a rationale for looking at classic psychedelics like psilocybin and LSD? And I think the answer is a resounding yes, at least from the perspective of, is there a signal there? Is there an effect size that we should look into? Yes. So we have momentum. The only question is, can we balance that momentum with a dose of reality? And we should maintain skepticism, and we should not lose sight of the fact that we really still need to do as solid and airtight of science as possible.
Yeah, absolutely. And I think this is especially poignant, in my opinion, just as a journalist, because we live in an era where I think whether or not same-sex marriage should be legalized has been a debate in English classes for 50 years, and whether or not marijuana should be legalized, same thing. And here we are. There's a lot of movement. A lot of people are waking up to some of the social issues that are not quite as taboo as they used to be. But at the same time, that means I think there are a certain population of people or patients who want certain things to do a certain thing. For example, marijuana. Like, maybe marijuana can make me less depressed. Maybe it can fix PTSD. But how would you think that you would direct the scientific community to say, like, let's make sure that we get the science, and then what would you say to patients to say, we need to approach this very carefully because it's not necessarily what you want it to be?
Well, I think actually cannabis is a good example here. There are lots of social and political movements that have really pushed the envelope in trying to get cannabis and cannabis products to either be, decriminalized or legalized. And there are plenty of people. If you look at any of the laws, the law in California, I think, don't quote me on this, but it says something like, it lists a bunch of different indications that California law says can be treated in California with cannabis, and it's like this, that, and the other thing, and any other illness. Like, it's just a blanket statement. You can do whatever you want with it under the law in California. That doesn't really actually match the science. There's very little science to support most of those indications. There's great science looking at the effects of certain cannabinoids on epilepsy. There's science to support the effects of certain cannabinoids on nausea, and frankly the literature and the evidence on pain is very mixed and not necessarily positive. And then if you get into all of the other indications that people apply personally under recreational or medical laws in a given state for cannabis, it doesn't necessarily add up. Lots of people are taking cannabis and cannabinoids for PTSD, and there seems to be decent evidence that you may be able to use cannabis to get to sleep, and you may be able to fight off night terrors, but your sleep architecture takes a real hit, and that itself has its own downstream effects. I think the benefit of the current approach in history towards psychedelics is that they're still treated as very powerful drugs because they are very powerful drugs. And I think people still have a real good sense of that. And so I think people are less likely to, or at least I hope people will be less likely to go off on their own and experiment. And and I can only hope that will give us a little more kind of freedom and space and time to really do the good science that's necessary to really evaluate the risks and benefits of the drugs, and under what therapeutic contexts are they most effective, and under what therapeutic contexts are the most risks expressed. So
right.
Yeah.
Yeah, I think it, like when you mentioned it before, that it's sort of like the Wild Wild West. You mentioned ketamine specifically as one of the things that seems to be new, but there hasn't been any movement. For junior research staff, is there something exciting happening here? Like, wow, we finally have something we can look into, and what about this for this and this for that? And how is the vibe at Johns Hopkins, which is, I guess, becoming ground zero for looking at this?
Can you restate the question?
What's the for the people doing the research? What's the atmosphere in the lab looking at these compounds? Does it seem? I would imagine my hypothesis would be that it's very excitable because there hasn't been anything new in a long time.
Well, there's a lot of enthusiasm in the lab for these compounds, and the enthusiasm, I think, is born out of the potential. I don't even want to say the promise. I just want to say the potential that we may. So it's something that gets me up in the morning. Frankly, is the potential that what I'm doing day in and day out may eventually help a lot of people.
Right.
And I think that sense is palpable, but it's also kind of tempered by the gravity of what we're doing. Yeah, it could really help people, possibly. We have to find out if that's true, and we have to do it carefully so that if there is medical value to these drugs, that we can describe it and identify it. And up until recently, there was even, and at some levels there still is, institutional concern. Hopkins itself doesn't want to put itself at risk. It doesn't want to put others at risk. And of course, these are a family of compounds that themselves have like I said, a very rich and sordid history, and politically and culturally. But we have the benefit of really forward-looking administration and dean and department chair who are very supportive of the solid scientific approach to understanding these drugs. So there's a lot of enthusiasm, but we also want to do it right.
Sure, and that makes sense, because if it's sort of being reopened, you want to get it right to make sure that the bricks are laid for whatever comes next, and there's no junk science, and everything is as tight as it can possibly be. I want to switch gears a little bit. You said this kind of gets you up in the morning, the opportunity to help people. So let's learn a little bit about you. Where'd you go to undergrad, med school, and why did you choose psychiatry?
Well, I'm not a psychiatrist.
Sure.
I didn't go to med school. But I completed my undergrad in music education.
Yeah, we're going to get into that.
At Temple University. Yeah.
Sure.
So my kind of obsession with the mind was initially born out of an obsession with trying to understand emotions and memory, and I was a musician for a good part of my life, and that was really driven by a deep need to try to explore myself and understand myself emotionally. And I actually did a double major in music education and psychology, and that was undergrad at Temple University. After that, I worked as a research assistant and a research specialist at the Schizophrenia Research Center at University of Pennsylvania, where I really kind of became obsessed with the brain and helped conduct studies of emotional functioning in patients with schizophrenia, both behavioral studies and studies involving brain imaging. And I had started with music. I moved into psychology and neuroscience, and then when I was applying to grad schools, I found a graduate program at the University of California, Davis, in the Center for Mind and Brain, in a lab that used music as a tool to study the brain. So basically a music neuroscience lab. I felt like I was able to pull things full circle.
Yeah.
And in grad school, I pursued using music as a tool to study emotion and memory in the brain, thinking, music is something that we all use implicitly or explicitly to regulate our emotions every day, or nearly every day. And how could we not use this as a naturally embedded stimulus, an ecologically valid stimulus, right?
Yeah.
So I pursued that in graduate school, and then it turns out music is complicated because people are complicated, right? We have these tricky things called preferences and idiosyncratic relationships with music that and for most people this song may evoke happiness, but for me it makes me very upset because it reminds me of my ex-girlfriend, and she dumped me right before senior prom, and I'm sorry I screwed up your experiment, Dr. Barrett. But I really kind of following this thread throughout my entire career in psychology and neuroscience, I've been obsessed with different ways and trying to apply different tools to study emotion and memory in the brain. And right about the time that I was hitting peak disenfranchisement with music, another grad student a couple of years ahead of me at UC Davis, Catherine McLean, she had been she'd been studying the effects of meditation on attention, and when she graduated, she moved to Hopkins to do a postdoc with Roland, and she had always wanted to work in this field, and I didn't know that the research was going on until she went to Hopkins to work with Roland, and they got money to run a study in which they would do brain imaging before and after a psilocybin session, and one of the questions they wanted to ask was whether they could look at the afterglow, or transient changes in emotional and mood. Emotional functioning and mood after psilocybin, and she thought, we could use music. I know a guy, and so she sent me this volley of emails like, how did you pick your music? How did you design your study? How did you analyze your data? How'd you interpret your data? How'd you find your subjects? And I kind of tongue-in-cheek sent her an email and said, hire me as a postdoc and I'll do it for you. And she said, okay. Really?
Nice.
Of course,
Love that.
Of course I'm going to do this.
Instead of like asking me how to do the work, just hire me and I'll do the work for you.
Yeah, but here was beset with this like opportunity, like music is complicated, but we know all kinds of things about drugs, right? Drugs are the perfect tool to study emotion in the brain, and turns out drugs are complicated because people are complicated, right?
People are complicated, yeah.
But I wouldn't change anything for the world right now, and I think that what we have in front of us are incredibly powerful tools that can cause radical behavior change, and understanding that radical behavior change and the biological basis of that radical behavior change has a huge potential to really enlighten and kind of inform our understanding of the brain and the mind more generally.
Yeah, absolutely. Is the door shut on your music research?
Oh no, it's actively ongoing.
Actively ongoing. So what? All right. So I want to get into a little bit about who and why you chose which music you did. Did you have a specific genre, song, artist, etc., that you prompted you to say, well, what the hell is happening to me inside right now? Maybe this is happening to other people. And what took it from something that you enjoyed doing and playing to this is something that maybe we should look at and put down on paper?
I mean, no one thing, just the entire experience. I mean, being a musician and performing in, I mean, I've run the gamut. I've performed in orchestras and jazz ensembles and community theater and the pit orchestra, and I've played in wedding bands and a salsa merengue band. I was a mummer in the Mummers Day Parade in a string band for 3 years.
For those of you that don't know, you can Google mummers. Yeah, we'll put a link to that in there. Yeah,
Google mummers, but don't judge me too hard.
Yeah,
no, it's a hell of a cultural oddity in Philadelphia.
Absolutely.
And I was my first real deep musical experiences were as a drummer in a Weezer Nirvana cover band that morphed into a hardcore punk band. So I haven't played country music, but that's about it.
Well, it's not if, it's when. It will happen to you. I promise.
I'm getting into bluegrass. It's growing on me.
I tell everyone, it's not if country gets you, it is when.
Okay,
it will happen.
Do you have a country history here?
Yeah, well, so I was born and raised in Wyoming. I got into audio by getting into radio. So I did sports, but I also did country music is everywhere. And there will be a day either you're going to be really sad or things are going to be really perfect. And the right country song will come on and you're going to be like, holy crap. Okay. This is exactly what my brain wanted. And it is perfect.
I can't wait.
Oh, it's going to happen.
All right.
Yeah, you're going to be driving down the road like, this is the driving song.
All right.
It's cruise control. All right, continue.
Well, so, I already have that with bluegrass. Yeah.
That's the gateway drug, I'm telling you.
It's perfect.
It's great.
Yes, please.
The way they play the strings, yeah, it's unbelievable.
Steve Martin?
Yeah.
Yeah. Anyway.
Yeah.
So yeah, there wasn't one song or one landmark experience. It was just, having grown up playing music and being involved in, playing music in the right context itself is an altered state of consciousness. It's really, getting in the groove and being in an ensemble where all of the musicians are playing well together. Everything's locking together. You're not thinking about what you're doing. You're just producing. It's flowing out of you, and it's flowing out of you in such an organic and kind of unifying way. It's hard to describe.
It is, yeah. That's why your research is really fascinating to me, because it's almost, music seems like something that in the moment has always existed, where you can't, like, why, there's no cognitive reason for somebody to come up with this other than that they did. And when they did, it feels like, yes, this has been around in my life in this moment forever. It feels perfect to me when you try to quantify that through research. I can't help but imagine that you'll get it must feel like you're often getting really close, but not quite being able to nail down that everyone is doing this one thing. There's no mathematical algorithm for that.
Well, yeah. As in terms of the evolution of music, there's a whole lot of armchair philosophizing and theorizing that's going on, but none of it's, you were never going to know the answer truly. But there is something fundamentally kind of human about experiencing and interacting with music, right?
Yeah.
And it's not the kind of thing. So, I mean, you could maybe possibly liken this to the hard problem of consciousness, right? We can explore and describe and try to dissect the contents of consciousness, but being aware ourselves of our awareness, we have to observe the observer. I mean, I'm not articulating this quite well, but I mean, I think there's an element of the hard problem of consciousness that also exists in the challenge of trying to really acutely and precisely describe what it means to feel and experience music. That kind of experiential element is going to elude this, really, really fine-grained scientific description.
Yeah. No, I mean, I understand what you're getting at, because it's impossible to put your finger on. Everybody, I call it the shake your booty concept, where every single song, everybody's got a song where, like, there becomes a point where you lose control of yourself. You start nodding along or singing along, and everybody's got it. It doesn't matter if it's a king or someone who's homeless at the time. Everybody's on the same page with whatever song does it for them, and that is beyond language. It's a very bizarre situation, but it's kind of beautiful, to be honest with you. It's like we all have this one thing in common. Yeah. Music is therapy. What are your thoughts on music as therapy and what we're looking at for the next 10 years?
Yes.
Got it. Yeah. Indicated. Yeah. Everybody.
Yes.
Perfect.
No. Yeah. I mean, I think that music is incredibly unique in its ability to kind of. I often think of music as engaging with music is a way to outsource our emotion regulation. I can personally attest to the fact that I listen to death metal and speed metal in traffic on the way home some days because I sometimes get angry in traffic, and if I just listen to this really kind of powerful, raucous, deep and heavy metal, I can feel that releasing, and it's cathartic, and it really helps me to regulate my emotions, and if you ask anybody on the street, what music do you listen to when you're happy? What do you listen to when you're sad? What do you listen to when you want to be happy or when you want to be sad? Everybody's gonna have an answer, and your answer may be very far from my answer, but it's probably right for you, and mine is probably right for me, and there are models of using music to guide imagery and kind of therapeutic process that exist. Some are better described than others, but this idea that you can use music as a therapeutic tool is certainly not new, and it's certainly a powerful one. I think that there's a phrase that people are really good pharmacologists. People titrate their caffeine intake. They often titrate their alcohol intake, and of course, you can come up with plenty of examples when people do that poorly or ineffectually or maladaptively, right? But it's probably a little less risky to do so with music, and people are pretty good at choosing music to regulate their emotions, and I think people use music naturally in a therapeutic way. The degree to which that can then be really formalized in an actual therapeutic context, there are people working on that, and it's a little kind of interesting digression in history right now. There's this approach called guided imagery with music, okay, which is a mainstay of bona fide dyed-in-the-wool music therapy. There are world congresses of guided imagery with music, and there are full professors at top-rate universities who are experts in guided imagery with music. People are trained in this. They go out into the world and they do this. It's a method of using music to kind of guide mental imagery and therapeutic process. It actually has its roots in psychedelic therapy. So there was this woman, Helen Bonney, who was a nurse at Maryland Psychiatric Institute in the late 60s and early 70s, and she was one of the individuals who's directly involved in psychedelic research in Maryland at the time, right up and leading to and through the Controlled Substances Act. And she herself was a nurse, but she was also a concert violinist, and and she was a complete musicophile and audiophile, and the value of using music as a tool to help people to navigate psychedelic experiences was clear from at least the late 50s. So, but a lot of people would, I'll say, play psychedelic DJ. You as a clinician and a therapist, you had your box of vinyl and you had your turntable and you had your patient who you thought you know really well, and after you administer a psychedelic drug, you're really kind of closely monitoring them, and you say, oh, now they need to calm down and put something calming on, or maybe they need something that's emotionally tumultuous to kind of mix things up. And so you were playing psychedelic DJ, and Helen Bonney came along and she said, well, wait a minute, there's got to be a system. We got to be able to come up with a system here. This just can't just be haphazard. So she and Walter Pankey came up with and published this paper in 1970 called on using music as in a therapeutic process during psychedelic therapy sessions. And when the Controlled Substances Act dropped and the human research was shut down, she didn't stop doing this. She really kind of came up with and continued that method, which grew into guided imagery with music. So music is therapy. Yeah, actually, that has a history tied directly to psychedelic research.
It seems hand in glove, as it were. So here's the question I have for you. What are your sense of the next 10 years of what you would like to, what would define success for the next 10 years for the psychedelic research being done at your institution and with your peers?
Yep. Success would be to get a clear answer on efficacy questions for mood disorders and for substance use disorders.
Yeah, I feel like that would be pretty successful if you get that question. It seems like we mentioned some specific indications earlier: PTSD, depression, substance use disorders. Do you think that I'm not going to ask you to guess because that would be absurd, but do you think that there's any sense that substance use is something that can be treated, specifically things that have been kind of sticklers like alcohol? Is there a psychedelic option, or do you think there are any avenues that are unexplored that we could be kind of seeing the sunrise?
I think that my colleague at Hopkins, Matt Johnson, has already published some really nice and promising research suggesting that there may be efficacy for treating smoking, and our colleagues at NYU, including Mike Bogenschutz, are in the same route of he's in the process of providing some nice evidence to suggest that there may be efficacy in treating alcoholism. And we have a colleague at University of Alabama, Birmingham, Peter Hendricks, who's running a controlled trial right now with patients with cocaine use disorder. And if each of these trials continues as they are going now, I think there's a good chance that we'll see some positive efficacy data for substance use disorders. And the real kind of head scratcher here, but the real kind of exciting thing at the same time is that, it's really one or a closely matched set of interventions for a wide range of substance use disorders, which isn't the way that it's approached right now. Sure. You have the nicotine patch for smoking, you have buprenorphine for opioids, and you have antabuse or whatever for alcohol. So it's a very different model, but that seems to be the case with psychedelics. Well,
it's quite exciting. I'm so glad to get to talk to you here at TEDMED 2020 in Boston. I got to get this nice little corner setup up here. We're having a drink. It's nice. Room. Yeah, it's nice. View. Yeah, it's we're looking right at the waterfront. We just had our cocktail hour at TEDMED. And Dr. Barrett, it's been a pleasure to talk to you. And you got to go pick up your wife. We're so glad to jam you in before you had to get to the most important part of the weekend.
Well, we'll see.
We're about to find out. Thank you so much for joining me.
Thank you.
A big thank you to Dr. Frederick Barrett for joining me on this week's episode of the Psychcast, episode 116, a correction from our introduction earlier. Remember, Dr. Jacqueline Posada is the author of the show notes. They're available wherever notes are found in your particular podcast app. It's time now for Dr. RK. Please welcome Dr. Renee Kohansky.
Hi guys, thanks for the intro, Nick. As my late dad used to say, unforeseen events completely change the course of nature. Or put another way, man plans, God laughs. You get the idea. So here we all are in a totally new universe. How are you guys doing? No, I mean really. I know we've been working in overdrive taking care of our people. So I'm just checking in on you. I know I had vaguely planned to incorporate telemedicine. And as it happened, I had signed up for my particular EMR's platform about 2 weeks before the end of life as we knew it. Probably maybe 50% of the time, I end up on a different and free HIPAA-compliant platform. But in this COVID world, and pay attention, it's a COVID world, the telemedicine rules on HIPAA compliancy are relaxed. Now you all need to know, I am maybe not the least tech-savvy person in the universe, but I am the sister of that person. So here I am, at this point, 100% on telemedicine. So you should also know there are 10 million zillion excellent web programs out there for you to hear all about telemedicine. In fact, the APA offers a free basic intro to telemedicine with CME, which I highly recommend. Many rules regarding telemedicine have been suspended because of COVID-19. However, if nothing else, you should all be familiar with the Ryan Haidt Online Pharmacy Consumer Protection Act of 2008. And the minimum take-home is that if you are going to prescribe controlled substances via telemedicine, you need to have performed at least one in-person evaluation. And keep in mind that that's even been suspended in some circumstances due to the COVID pandemic. Now, this is coming to an end, so keep that in mind. A few other minimum telemedicine pearls are that you need to be licensed where the patient is located. And when you are on the visit, document in your chart the address where the patient is physically located. So say the patient is talking to you on their cell phone and they're sitting in a car in front of some grocery store. Get the address of the grocery store that the patient is located. This is in case there's an emergency and you need to send emergency services. You already want to know the address that the patient is located. I'd also say pay as much attention to your virtual office as you do to your real life one. Be aware what is in your background, keeping in mind that you want it as professional as possible. Remember, our offices are part of our boundaries. So here are some of my thoughts as I ventured into this not-so-new land. There are physicians who absolutely love this medium. They feel they can experience as much with their patients via telemedicine as they would in person and find it to be a very fulfilling way to practice medicine. They've done their due diligence, checking with their insurance carriers and their state-specific legal requirements. I'm currently finding the niche in my practice where this can serve as an adjunct. I find it reassuring that while this medium is new to me, it has in fact been around long enough that many of the kinks have been discovered and already navigated. I have downloaded how-to videos on doing a telemedicine neurocognitive exam and an AIMS exam. Now that being said, I can still detect the most subtle of cogwheelings. It's actually one of my super-duper superpowers. No telemedicine examination can do that. Now one can argue, well, there really isn't a huge need for that, but it actually truly depends on your practice, right? I've picked up a number of neurologic disorders by doing simple physical examinations such as these. I love the fluidity of being able to see a person on telemedicine if they have a minor physical ailment that might otherwise keep them out of my office, or a babysitting issue, or car trouble, etc. These are potential no-shows that can now be captured. There is also something to be said for a 35-second commute to your office. As I've stated in other programs, I believe we are in the age of psychiatry. We are particularly well-suited for a telemedicine model, and we are uniquely poised to provide an extremely high level of care working in the mind-body interface. I'm Dr. Renee Kohansky for the MD Edge Psychcast.
And that concludes episode 116 of the Psychcast. Let's get to this week's credits. The Psychcast is hosted by the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris. The Psychcast is produced by MD Edge editors Gina Henderson and Jeff Bauer. The show notes are authored by Dr. Jacqueline Posada. I conducted this week's interview, my guest with Dr. Frederick Barrett, PhD, Johns Hopkins University. TEDMED episodes of the Psychcast are produced by Eamon Nadell, as well as Brett Setka, with special thanks from Crystal Nadoni. All MD Edge podcasts are produced by the editor-in-chief of MD Edge and Medscape, Dr. Ivan Aransky, as well as MD Edge executive editors Mary Ellen Schneider and Kathy Skarbeck, multimedia editor Terry Rudd, and social media producer Kyla Clark. I am your audio engineer, audio editor, and the host for this week's episode, Nick Andrews. You're listening to the Psychcast by MD Edge.